Wonderful, thank you. All right, on behalf of Healthcare Authority, I'd like to welcome you to our Q&A webinar. Today's webinar is on the Cascade Select public option rulemaking. The public option plans that are available under Cascade Care are also called Cascade Select, so that's how we'll be referencing them in today's webinar. All right, so we are recording today's webinar. So if you do not want to be recorded, please turn off your webcam or your video. And at this time, we have muted all attendees, which means that you can hear us, but we cannot hear you. But there's going to be time at the end for Q&A, and we encourage all participants to submit questions and comments through the chat function. And you can do this during any part of the presentation. You don't need to wait to the end to ask a question. And if you wish to verbally share your input, please raise your hand using the raise hand function, and we'll call on you during the Q&A, which will be coming up pretty soon. And the raise hand function is under the reactions section of Zoom. So today's slide deck and recording will be available on our Cascade Care page. It takes about a week or so to post the recording, but the slide deck is available right now on that webpage. Okay, so let's introduce today's presenters. So today we have Michelle Needham, and she is the Healthcare Authority or HCA Chief Policy Officer. We have Annette Schopenhauer, and she is HCA's Chief Legal Officer. And my name is Rochelle Olangi. I'm not presenting, but I'll be kind of the MC moderator for today, and I am the HCA Policy Communications Manager. We would love to meet you. So if you are comfortable, please give us your name and your organization's name using the chat function. And you're welcome to do this at any part of the presentation. You don't need to do it immediately. We would just love to know who's here today. All right, so we'll go through the agenda just really quickly and then we'll get started. So for today, we're going to spend some time talking about the background for Cascade Select. And again, those are the public option plans available underneath Cascade Care. We'll be sharing the new legislative changes, talking about the next steps for rulemaking, and most of our time today is going to be spent in that Q&A session. It's really important for us to hear from you and hear your questions and comments. And last, we'll share some contact information and some additional resources. So next, I will hand it over to Michelle Needham. Michelle.
Thank you, Rochelle, for getting us started and for being our meeting moderator today. I really appreciate that. So I will start into some of the background and assume people might know something about it, but just in case, as a reminder, the legislature passed a bill in 2019 that created the public option or Cascade Care Select program in Senate Bill 5526. And the focus on that bill was to create affordable options within the health benefit exchange offering, really focusing on some standardized benefit plans that have, in fact, more services before deductible and trying to reduce premiums and ensure some statewide access for people through that program. For those of you that may remember, we have implemented the first year of coverage in 2021. That RFP was issued in 2020 and coverage is starting January of 21. So we now have plans in place. There are 5 carriers offering that product currently. In the 2021 legislative session, they did pass an additional bill refining some of the guidance around that program with Senate Bill 5377. And that includes a couple of new requirements around provider participation, and that'll be the focus of the rulemaking. Next slide, please. And so, as I just noted, the Cascade Care Select became available with active coverage on January 1, 2021 through the Health Plan Finder, is a product on the Health Benefit Exchange list of offerings. We have 5 carriers offering those plans currently, and they do have a 2-year contract. So they have just expanded some of the coverage areas for 2022 with their Office of Insurance Commissioner filings. We'll have plans available in 25 of the 39 counties beginning in January. We are also in the process of discussing and planning for our next procurement phase for the plan year 2023 coverage. And we will anticipate having some procurement released in approximately February of 2022. So be looking for that this winter. Next slide, please. The changes that were passed this year in Senate Bill 5377, of particular note is Section 5 and the requirements to ensure statewide availability. The legislature is focused on us trying to ensure coverage in every county. So we have a few more counties to expand coverage to, as I just noted. And the language specifically calls for us to have all hospitals that receive any payment for services from essentially the healthcare authority programs, either in the Public Employee Benefits Board program or School Employee Benefits program or through Medicaid. Any hospitals that receive funding or services in any way from those programs must contract with at least one public option plan to provide in-network services to enrollees for our Cascade Select program. And to ensure that process, we have been given authority to adopt some program rules in consultation with the Office of Insurance Commissioner and think about how we would ensure compliance and potentially levy fines or other incentives to help participation. So that's the nature of our discussion today, is help us think through some of that process. We have not begun drafting the rules. We're here to think with you about what they might look like and get your input and feedback today. Next slide, please. So we have started thinking about the rule writing and certainly have filed our initial process with the Code Revisor's Office, beginning that development work. And this conversation with you today is part of that process to gather some stakeholder input and think through some of our early draft language. And we will be sharing that early draft as soon as it's ready. And then we will, of course, have an open public comment on those draft rules, and we be refining and working on rule finalization, all with the goal of having the rules in effect as we make procurement selection in the late spring, early summer. So we are on a trajectory to have things in place for that cycle. Next slide, please. All right, so now I'm going to turn it over to Annette, who is leading our rulemaking efforts in our legal shop, and she's going to lead some discussion. Thank you, Annette.
Well, again, good afternoon. It's really great to see 142 participants in our webinar today. If you are coming to hear about a whole bunch of information from us, you're going to be wholly disappointed, because we're here because we really want to hear from you. We understand that this is the first time we've done rulemaking for Cascade Select, and it's the first time we've had to implement mandate on providers. We really want to understand your feedback, issues, and concerns before we start that process. It will help guide us. So we have a few slides with a few prompt questions. You can either raise your hand if you want to share some information, ideas, or thoughts, or you can put it in the comment bubble. I'll try to be watching for people who raise their hands, but Rochelle will also help us out here if I miss somebody. So question number 1, what should HCA take into consideration when developing rules to enforce the requirement that each applicable hospital must contract with at least one Cascade Care plan, Cascade Select plan? Stated another way, why'd you come today? What interests you about this rulemaking, and what do you want us to know about it? it's okay if you don't have ideas popping right to your head. We will be happy to hear feedback from you outside of today's webinar. If you want to send us ideas and thoughts and not have it recorded on the webinar, I understand that too. We wanted to make this form available to you. So I'll give it another moment for you to think about, what do you think we should be taking into consider? Oh, great. Thank you, Gerald. What is the safeguard that plans do not have a conflict of interest in the line of business? I don't know. Tell me more about conflicts of interest and what you want us to know about that as we think about this. Must the rates conform to a rate cap for every individual hospital? That's a good question. What's the concern around conflicts of interest from your perspective? Gerald, did you want to share any more? We could unmic you if you wanted, or unmute you. Beth says a healthcare delivery system may also be a healthcare carrier. Right, that could create an interesting dynamic. Is there safeguards that you could put in place? Would you assume that there would only be one carrier offering in your county? Okay, thank you, Gerald. Gerald indicated that experienced health plans may have been in the business of health insurance, which may be a conflict. Any other information you want to send us about that or share with us? Would like to learn more. Does HCA have a plan to develop standards regarding what is considered an offer from the health plans? Is there a reasonability standard? That's a great idea. It seems like that could be a really good thing for the HCA folks to talk about and think about. I think that's a great idea. Would having standards available, or reasonability standard, if we were to put that in rule, would that help the hospital providers be able to contract with Cascade Care Select plans? Yeah, okay, great. We'll take that. You guys are awesome. Thank you so much. You're already giving us good meat to think about. The next one here from Mike is, how will you address the physician participation, non-participation, especially given the no surprise billing policies? I believe it's more of a hospital participation. I haven't thought about it at the line level physician participation level. That's something we can talk about or bring back. If you have any more thoughts on that, let me know. But the way I've read, the way I've been looking at the RCW, it's more about the hospital system itself. But you can't have, yeah, that's true. You cannot have adequate network without physician participation. That is true. Crystal says they can offer whatever rates they want to the providers, but they get capped on the money. So Crystal, is your concern here with the rates piece about fairness in contracting with rates? Or is there something we can do in the rule that would help solve that problem? Okay, thanks, Crystal. Let's see. I'm keeping up with everybody. Joanna indicated that there's concerns regarding the parity of rates that have already established commercial contracts, and that it could erode currently limited commercial populations. Would payers be incentivized to terminate current commercial lines of business for more lucrative rates under Cascade Care? Oh, that's an interesting question, because the idea here is to expand coverage and access so people in Washington can receive care. And so that seems like that would be about outcome. Is there things we can do in rulemaking, though, that you think might help address that concern? Do you think HCA should be, I'm thinking on the fly, when we set out criteria, would it help the hospitals if we take a very detailed approach to the rulemaking with lots of guidance and regulatory controls? Or would you rather have HCA be more outcome-based? Was there a contract? Was there an offer or not? What do you think is the fairest way to judge whether or not a hospital has met the requirement? I'm hearing outcome-based. That was just honestly, that was my initial thought, was outcome-based would probably be the most direct way. But we're really just at the starting point here. And Leah, HBE's shouting out that when thinking about the goal to have statewide coverage for Cascade Care Select plans that need adequate networks, any thoughts from the group about hospital participation where a hospital is needed for network adequacy in more than one county? Anybody have thoughts on that one? We can go to question 2. This is fun. Next question. What do you, and I think you've already started talking about this, but what do you think are the key barriers for our hospital contracting with the Cascade Select plan, or vice versa? And how can HCA's rulemaking help resolve these concerns? Are there concerns about timelines with when things have to be contracted and procured versus when certain documents must be submitted to the state? I know that there's quite the process within this whole system from a carrier's perspective, or offering a plan of how they move through the process. Are there concerns with that we should be thinking about ways to reduce barriers that we could do through rulemaking? If you have ideas, send me a note. Let me know, okay? Let's see, a couple more is coming in. Mike's noting the hospital's ability to manage increased uncompensated care burden. Yes, Dally, I'm not sure who that is. Indicated or stated the rate cap is at commercially unacceptable levels, particularly post-pandemic. With government setting the price, it makes the contracting process more challenging, and there's no VBT component, value-based purchasing component. What does the state see in legislation that would encourage providers to participate? That's a negotiated, okay, Sarah indicates that negotiated rates may be a barrier. Less rates may not adequately cover cost of care. If HCA is willing to play arbitrator in rate resolutions, that could be a remedy. You know, that was one of the things I was looking at. Is there a way to help bring people together? I'm not saying HCA would be an arbitrator or an arbiter, but I think that there could be a role for the state here, and interesting to hear your thoughts. let's look at. Yes, any rulemaking must be coordinated with the OIC. That is correct. We have close partnership with the OIC. Andrew indicates viable rates are one concern, but administrative burden, timely payment, and preservation of the continuity of care are also barriers to contracting. Interesting. Okay. Oh, thank you, Suzanne. Thank you for spelling out your whole name. I know you did earlier, but I lost it in the big chain. And Julie indicated low participation in the plans make it difficult to operationalize multiple plans. That's wonderful feedback. Is there a role the state could play through the rulemaking? Something that you think that, oh, if HCA just did X, Y, and Z, then it would be better. All right, next slide. So the next one's on the compliance piece. What should HCA consider to ensure compliance with the requirement that the hospital providers are contracting? Is there, the legislature left it pretty broad for HCA to decide for rulemaking, contracting actions, levying fines. All of our hospitals are very valued and important providers for the healthcare authority. And certainly, you know, we want to hear from you as we're thinking about what is a fair way to enforce these requirements. One that meets the legislature's intent that hospitals are contracting with select plans so that we can get statewide access so that patients can get care. But at the same time, I want to ensure the process that we put together is reasonable and fair and is effective. Effective in that it encourages hospitals to contract with select plans. So what are your thoughts on this one? Jim indicated that the administrative burdens placed on the hospital by some of the carriers are quite significant and frequently receive administrative denials for medically necessary services. Is there something HCA can do in the rulemaking to help providers with that? I don't know, but I will find out. I will look into that. I will see if there are ways to build something like that into the system and see if it's possible. Other thoughts? I don't know. So Gerald asked a good question regarding number 2, whether or not CMS's Medicare allowed rates and rules such as the 24-hour rule are in effect for the public option plans. These plans aren't under Medicaid themselves, if I remember correctly, the select, the Cascade Select. And so I'm not exactly sure how the Medicare rules follow on that. So we'll have to phone a friend on that unless somebody else on the phone line here knows the answer to that question. Oh, interesting. Thomas, thank you. Instead of assigning fines, assign an administrator to some cases. Do you want to expand a little bit more on what you're thinking about that? Would that help attract and bring in a plan to that hospital when contract negotiations aren't working, or would that be after the fact, after the hospital has already been in non-compliance for failure to get a contract? And Mike offers here, what about carrot versus stick approach, supplemental payments for hospitals and networks that experience significant higher access rate? Let's see, new information and guidelines, see if cases are failure. Do you want us to unmic you, Thomas, so you can kind of expound a little bit what you're talking about? It's okay. But I think I picked up what you're putting down, thinking about alternatives to sanctioning and find some way to actually solve the problem of getting plans with the hospitals connected in a way so that we have, what meets the goal, which is statewide coverage. Unfortunately, I think we saw in the earlier slides that we've hit plan year 2022 and we don't have statewide coverage. So that makes getting this rule done, making it right, is so important. Ashlyn asks the question, wants to know whether or not HCA expects to procure additional carriers for the next procurement and to increase the coverage service area through contracting with additional carriers. We're still working out the logistics internally of exactly what the procurement design is going to be, but it will be aimed towards, again, like we're talking about, statewide coverage. We want everybody to have care. The details of it, we don't quite have ready to, we don't have finalized. And so I don't think we can answer that question. I'll pause and see if anybody on the HCA line knows something other than me on that topic. And if not, I can tell you that we will be providing more information in the future as we get closer to procurement. There's a lot of the design elements to the procurement that we're still talking about on the policy level internally, working out. Next slide. I think it's question 4. Back a slide.
I'm sorry, Annette. I don't know what's happening here.
All right, I know. I already know what it says. So what I wanted to ask this group is, if we take an enforcement action, what kind of due process do the provider hospitals want? Sometimes when we take a contract action, we do informal dispute resolution just internally. Sometimes when we take action with a provider, like an overpayment where there's money involved, or a fine or a penalty or a sanction, we offer full adjudicative proceedings. And I was curious here, since we are determining the appeal system, what kind of appeal system do you think is fair for providers and hospitals to have if HCA were to take an enforcement action? For instance, when we launched drug price transparency program, we built in a couple of steps of opportunities to cure prior to taking an action, and some others. And I'm not saying we could replicate that here, but it's just an idea prompt for the group that there might be alternatives for us to consider. I just don't know what this group feels is best for hospital providers. Thanks, Beth. You like the following the Administrative Procedure Act, give them the full adjudicative process of a full adjudicative proceeding. I can tell you that's kind of where I'm leaning towards. And I wanted to check in with this group and see. Anybody else have thoughts? Anybody think that it should be something other than a full adjudicative proceeding? Arbitration's expensive. If we do an APA adjudicative proceeding, you wouldn't have to pay for the judge. We would use probably our central panel contract with the Office of Administrative Hearings to conduct the actual admin hearing, though I don't know for sure, but that's probably what we would do. Let's see, allow a 90-day cure period prior to the adjudicatives. So look for some way to resolve these at a lower level. See if we can build that into the process somehow. Others? All right, let's see, peer review. What would that look like? Would that be like the contract that was offered, but not to see whether or not it'd be like a reasonable contract, Gerald, or something? Mike offers a good question. Is HCA assuming that the failure to reach a negotiated arrangement is always the hospital's fault? Others? Yeah. To answer your question, Mike, I wouldn't assume that. Takes two to tango, but what would be interesting is how do we build the rules and the program out? So that's where your comment and questions and really good one. Looks like Crystal agrees. All right, if nothing else on kind of the appeals enforcement part, I just open it back up to the group. If there's any additional information you would like us to think about and consider. Again, this isn't your only opportunity to provide us input. This was just to get the ball rolling. You're welcome to send us information after today's meeting that will go to the team that's working on it and thinking about it. And when we have a draft regulation available, we'll share it with this group so you have a chance to provide comments before we file a CR 102 for those who sign up for the rulemaking process. It looks like Beth has a comment here. There are standards in place for good faith negotiation with essential community practitioners in the ACA to consider. Thank you very much, Beth. And Jim, are there going to be similar rules in place on the carriers who have contracted hospitals in each of their markets? That's an interesting way to think about it too. So I'll take that back to the team to talk about if there's some things we can do through rulemaking that encourages the carriers also to seek out the contracts and all the counties as well. Anybody else have thoughts?
Hey, Annette, this is Rochelle. I just wanted to, it looks like Sarah, a couple of messages before had talked about the concept of an appeal process. I'm not sure if you saw that note, but I wanted to call that out.
I did not. Thank you. That one zoomed past me. Sarah says yes to the concept of the appeal process, but it might be more proactive if the hospital could be required to register with HCA if they're having issues with contracting with a particular carrier of Cascade Select and document the issues at the point before it gets to fines or sanctions. That's a great idea. Thank you for that suggestion. Any other ones you think I've missed?
I just saw that Beth popped up with a latest message at the very bottom about carriers must meet network adequacy for hospitals or
Okay.
with hospitals.
Yep, there are network adequacy requirements. Yeah, we have a timeline. It's kind of under development right now. I don't think we have a PDF that we could send out to this group, but we could follow up with this group and send you a timeline of when we anticipate. We send those out. That's just our anticipated date. Things might move a little bit, but we could give you an idea of when we plan to release draft rules prior to the more public hearing process. So stay tuned. Yeah. Anybody else? Next slide. Oops, she goes so fast. All right. So if you want to learn more about Cascade Care, there's some links here on the webinar that you can click on. We have the link to the meeting. I think you'll be able to click those links. Rochelle, they'll be able to get into the slide deck and click those links. Is that correct?
Yes, absolutely.
Okay, and if you want to sign up to get an early copy of the proposed draft rules, just contact Melinda Froud to get on the list, and you sign up for the rulemaking gov delivery notices, and you'll be sure to get all the information in. And again, if you have ideas or thoughts, shoot us an email and tell us your thoughts and your ideas. It's great for us to have input from you as we develop these rules. Anything else from anybody? All right, well, on behalf of the Healthcare Authority, we thank you so much for attending today's webinar, providing us your input. We'll follow up with you if we have questions about your comments or your ideas. Otherwise, we welcome you to send us information. Let's see. Well, one more question came in. Is there a requirement around controlling the cost of premium? Is there a requirement of controlling the cost of premium in the rulemaking? Can you expand a little bit more about your question? Are you talking about for contractors who are, for carriers who are responding to the procurement for to be a Cascade Care Select plan, or are you talking more on the consumers? Yeah, for the consumers, for controlling their premiums. That right gets into benefit design. Michelle, I'm not sure if you can take that one or if that's something that we can follow back up on.
Yeah, I think I'll go back to your answer around the procurement development and the policy decisions we're still working on. So the procurement that will be released in February or March will talk about some of those requirements. And that's about all I can say at this point.
Under development. Anybody else want to speak in any more before we close it out today? Thank you, Rochelle. All right, thank you, Michelle and Rochelle, and thank you everybody for coming today. I know you're going to get 20 minutes back. I hope you have a wonderful Monday. Thank you for being engaged in Healthcare Authority's rulemaking. We look forward to partnering with you on Cascade Care and look forward to hearing from you as we continue this adventure.
Yeah, thank you, everyone, and thank you, Annette. Have a great afternoon.